Chapter 30, Care of Patients with Disorders of the Liver, Gallbladder, and Pancreas. Theory objectives. Explain the plan of care for the patient with cholelithiasis. Describe treatment for the patient with cholecystitis. Compare the ways in which the various types of hepatitis can be transmitted. Identify signs and symptoms of the various types of hepatitis. Devise appropriate nursing interventions for the patient with cirrhosis and ascites. Indicate potential causes of liver failure. Differentiate the signs and symptoms of acute and chronic liver failure. Discuss the criteria used for selection of liver transplantation recipients. Devise a nursing care plan for the patient with cancer of the liver. Prepare a plan for adequate pain control for the patient with pancreatitis. And compare the treatment options for cancer of the pancreas. Clinical practice objectives. Perform preoperative teaching for a patient who is to undergo laparoscopic cholecystectomy. Evaluate a nursing care plan, including psychosocial concerns for the patient who has hepatitis with jaundice. And implement a discharge teaching plan for the patient who has been in the hospital with a flare-up of chronic pancreatitis. Cholelithiasis and cholecystitis. Well, cholelithiasis is the presence of gallstones within the gallbladder or in the biliary tract. It develops when balance between cholesterol, bile salts, and calcium in the bile is altered, and it causes precipitate, the formation of stones. Increased risk factors for cholelithiasis: sedentary lifestyle, familial tendency, diabetes mellitus, obesity, also gastric bypass, and being of Native American or Mexican American descent. Additionally, if you are a woman, you're at an increased risk, and if you're over the age of 40, you're at increased risk. Cholecystitis is inflammation of the gallbladder. Signs and symptoms of these conditions include pain, which may be either just really slight or none, to severe or unbearable pain that feels like a crushing heart attack. Additionally, these patients may experience biliary colic. Diagnosis. We'll do an ultrasound or ultrasonography, a CT, an ERCP or endoscopic retrograde cholangiopancreatography. We'll do a HIDA scan. We'll do liver function tests as well. Treatment. We'll change the diet. Low-fat diet, correction of bile obstruction, antibiotics if there's infection and inflammation, and cholecystectomy is the removal of the gallbladder. Complications include potential fistula, peritonitis, and pancreatitis. So here's nursing management, pre-op care. We're going to control pain for these patients. We're going to provide education for these patients. Post-operatively, we're going to be assessing their pain, assessing their ability to pass flatus, to have a bowel movement. We're going to prevent constipation and encourage early ambulation. And then caring for a T-tube. Our T-tube is going to drain to gravity. So we want to make sure that we're changing that once per shift, emptying out the fluid. We expect any kind of biliary drain to have anywhere from 500 to 1,000 milliliters of output. And that is normal for a shift. Hepatitis, the etiology and pathophys of hepatitis. There are 5 different types of hepatitis. It's viral, A, B, C, D, and E. Hepatitis causes extensive inflammation of the liver tissue, and it may form fibrous scar tissue. Hepatitis A and E are transmitted primarily by oral fecal route. Hepatitis B and C are transmitted primarily by parenteral routes or IV, and also sexually. Hepatitis D coexists with hepatitis B or C virus and is transmitted in the same ways as B and C. Viral replication phase, okay? No symptoms when you're getting the virus. During the prodromal phase or pre-icteric phase, you may have nausea, fatigue, flu-like symptoms for the prodromal or pre-icteric phase. During the icteric phase or the dromal phase, patients will have jaundice. Their jaundice levels will rise to double the normal level of their bilirubin will rise to double the normal level of bilirubin in the blood. And when it is double normal, approximately 36 or so, they'll start to develop that jaundice. The convalescent phase or post-stromal, post-icteric phase, jaundice starts to disappear. And so do the malaise and fatigue. These patients are starting to go back to normal. Diagnosis of hepatitis, we'll do serological assays or enzyme immunoassays. If we have hepatitis, we're going to see hepatitis antigens present in the blood, or specifically specifically hepatitis B surface body antigens. If we have recovered from hepatitis, specifically hepatitis B, we'll see antibodies to the hepatitis B. Um, but while we're currently infected, we will see those hepatitis B antigens, surface body antigens. A liver biopsy will help us diagnose hepatitis as well. Also, an elevation in LFTs. LFTs include AST, ALT, alkaline bisphosphonates, total protein, albumin, all of that good stuff. Treatment of hepatitis. Well, with Hep A, we're going to rest, avoid substances that can cause issues with the liver, like Tylenol, eat a well-balanced diet, and then we may give an immunoglobulin for hepatitis A to help encourage recovery. For hepatitis B, we're going to do drug therapy to decrease the viral load and also administer immunoglobulin. And then hepatitis C, they're going to be on antiviral medications. Cirrhosis. So hepatitis B and C, alcoholic liver disease, and non-alcoholic fatty liver disease are the leading causes of cirrhosis. There are other causes. There's biliary cirrhosis and cardiac cirrhosis, but hepatitis is the primary cause of cirrhosis. Oftentimes that's the post-necrotic cirrhosis that results from the damage done by by hepatitis in the liver. Normal hepatic structures are destroyed and replaced with fibrotic tissue in the cirrhosis pathology. Liver biopsies, liver function studies, CT and liver scans, and magnetic resonance cholangiopancreatography are going to tell us if we have cirrhosis of the liver. Treatment is to stop the liver damage, whatever caused it, we need to stop, prevent further liver damage, and manage the symptoms of the cirrhosis. We should restrict these patients' fluid intake and also their sodium intake, and we may put them on diuretics like Lasix. Cirrhosis signs and symptoms. Wow, there's a bunch of them. Fatigue, weakness, headache, anorexia, indigestion, abdominal pain, nausea, vomiting. Fluid retention, especially in the right hemothorax or ascites, can limit the expansion of the chest and cause dyspnea or difficulty breathing. Objective symptoms of liver cirrhosis include excessive gas, skin rashes, itching, and fever. Leg or foot edema, palmar erythema, caput medusa, bleeding or bruising, vitamin K, thrombin and prothrombin deficiencies, palpable enlarged and knobby liver and enlarged spleen, abdominal distension, peripheral edema and ascites, skin lesions, jaundice, pruritus, bleeding disorders, endocrine disorders, peripheral neuropathy occur late in the disease. And then there may be spider angiomas of the face, neck, upper trunk, and arms. Lots of symptoms with the cirrhosis. Signs and symptoms of cirrhosis: neurologic, they may have hepatic encephalopathy due to the rising pneumonia in their blood, peripheral neuropathy, asterixis, which is characterized by tremors. They also may have jaundice, spider angiomas, palmar erythema, purpura or petechiae, those splotchy, bruise-like rashes, caput medusa as well. They may be anemic, thrombocytopenic, leukopenic. They may have coagulation disorders like increased PTT. They may have an enlarged spleen. Metabolically, they may be low in potassium and sodium and albumin. Cardiovascular, they've got increased fluid, so fluid overload. They may have peripheral edema or ascites. Reproductive, so women are going to not have periods. Men are going to have testicular atrophy. Men may develop gynecomastia or the development of breast tissue, and this may cause sterility or impotence. Gastrointestinal symptoms: anorexia or decreased appetite, dyspepsia or heartburn, nausea, vomiting, change in bowel habits, dull abdominal pain, the fetor hepaticus, which is that musty breath, esophageal and gastric varices, gastritis, hematemesis, which is blood in the vomit, or hemorrhoidal varices. These are all signs and symptoms. Relationship of systemic portal hypertension and ascites and cirrhosis. If you look, you can see that liver cirrhosis causes portal hypertension, which causes an increased hydrostatic pressure in the portal circulation. Liver cirrhosis also causes blocked lymphatics, decreased synthesis of albumin, and decreased blood volume, plus reduced inactivation of aldosterone and ADH. And because of all of these, we have increased fluid in the peritoneal cavity, decreased plasma osmotic pressure, and fluid shifts out of the portal circulation into the peritoneal cavity, and increased serum aldosterone and the antidiuretic hormone, which can cause an increased sodium and water retention, which all three, all four, all five, six, seven of those lead to ascites. Complications of cirrhosis include esophageal varices, encephalopathy, which includes symptoms of delirium, convulsion, asteriscus, and coma, and then that fetor hepaticus, or that stinky, musty, sweet breath. Treatment for esophageal varices. So we know that esophageal varices are like hemorrhoids of the esophagus. So this is a picture of of the endoscope positioned over the varix, and then they apply suction to draw the varix toward the endoscope, and then they'll put a little ligation band around the varix, and then the band remains in place there. Liver transplant, there are always legal and ethical considerations. People are put on a list for transplant. They have to be willing to change their lifestyle, including give up alcohol if that was what caused their liver issue to begin with. They must also enter rehab if they're on drugs, and those kind of social activities may limit their ability to get a liver transplant. They may not be considered a good candidate. Excuse me. So liver transplant is considered for patients with progressive and advanced liver disease that do not respond to treatment. Want to make sure we care for the drains. We put them on immunosuppressants so that they don't reject their new liver, and that we do liver function monitoring to make sure that the liver is actually working once it's received by the transplant recipient. Cancer of the liver. So metastatic liver cancer is much more prevalent than primary liver cancer. What that means is usually cancer that ends up in the liver does not begin in the liver. It begins somewhere else and it metastasizes to the liver. There are two types of primary liver cancer. However, there's a hepatoma, which arises from the hepatocytes, and there's cholangiocarcinoma, which is bile duct cancer. And those are the two that actually do originate inside of the liver. Patients that have cancer of the liver usually have right upper quadrant pain. They may feel very tired. They may have a loss of appetite or weight loss. They may be weak. They may have fever. And they also might have the signs of poor liver function. Liver cancer treatment includes a surgical resection of the liver, a liver transplant, radiation and chemo, tumor ablation, or laser or radiofrequency ablation. Acute pancreatitis. So inflammation of the pancreas is what pancreatitis is. It can be acute or chronic. It frequently accompanies obstruction of the pancreatic duct by gallstones or from backflow bile into the pancreatic duct. Signs and symptoms include epigastric or left upper quadrant pain, nausea, vomiting, sweating, jaundice, weakness. Sitting or leaning forward may help decrease the pain. Also, the severity of the pain may slowly decrease after the first 24 hours. Eating does make pain worse with pancreatitis. So here's a pathophys chart of acute pancreatitis. Precipitating factors of acute pancreatitis include alcohol consumption, biliary tract obstruction, cancer, and the virus that causes the mumps. And that all of those can cause an activation of pancreatic enzymes inside the pancreatic ducts. And so basically the pancreas is eating itself, or it's auto-digesting the pancreatic tissue. Because it is eating the pancreatic tissue itself, tissue necrosis and inflammation occur. Enzymes and cell contents may leak into the general circulation, which can cause serious issues like DIC, or disseminated intravascular coagulation, adult respiratory distress syndrome, or shock. Our body cannot handle the enzymes that are supposed to belong in the pancreas. And active enzymes may also leak into the peritoneal cavity and continue to destroy tissue with massive inflammation. So peritonitis, hypovolemic shock as we begin to hemorrhage, and then also severe pain. I mean, it's just not going to be comfortable whatsoever. Acute pancreatitis treatment includes pain evaluation and control. That's going to be our primary intervention with acute pancreatitis, is to control the pain. Additionally, we want to eliminate alcohol intake, make sure that these patients are having small, low-fat meals, that they have enough hydration, and that they're on pancreatic enzymes. And they do need to always take those pancreatic enzymes. Nursing consideration, we must be supportive of their efforts to abstain from alcohol. Cancer of the pancreas is really not known why it happens, but it's more common in men than women, and it occurs more often in people that are older than 55. Um, Potentially, cigarette smoking can cause it. So, adenocarcinoma is the typical pancreatic cancer. There can be a tumor in the head of the pancreas, the body, or the tail, and they can do a Whipple procedure to resect. Epigastric pain and weight loss are your symptoms. Also, loss of appetite, vomiting, jaundice, and these patients may also start to form clots. Ultrasound, imaging, needle biopsies, elevated embryonic antigen levels, serum beta human chorionic gonadotropin and carbohydrate antigen or CA72-4. Also, tumor markers CA19-9 and CA242 are going to be indicative of cancer of the pancreas. What are we going to do? We're going to keep this patient comfortable. We're going to treat and prevent malnutrition for them. Surgical treatment, as I stated, includes a Whipple procedure or a radical pancreatic duodenectomy. The surgery is used to relieve the symptoms of obstructive jaundice and severe pain, etc. Um, Radio frequency ablation or microwave therapy may be used. Additionally, radiation and chemo may be used to treat the cancer of the pancreas. So here's your audience response. Question one: the nurse caring for a patient who has undergone a radical duodenectomy should consider or monitor for which postoperative complication. So I'll give you a second to think about what it might cause. And I'll show you the answer. The answer for this one is hemorrhage, bowel obstruction, or intra-abdominal abscess. And that is the end of this PowerPoint presentation. Of course, if you have any questions about disease processes and disorders of the pancreas, the gallbladder, or the liver, you can always reach out to me. Thank you very much.